Hi everybody. I'm a GP in Surrey, and I've got an academic post at St George's, but I'm presently doing HEE-funded MSc in genomics, and this has been something, genomics and genetics have been a long interest of mine for many years. I think in terms of our sort of exposure to genetics and genomics in primary care, I think most GPs would say, well, how is genetics and genomics going to actually help me, in terms of day-to-day practice? And there are certainly some drivers coming through that are going to increase our exposure in primary care. And these are sort of largely patient-driven. So patients are going to engage with secondary and tertiary services where they may be tested. Patients may have access to direct over-the-counter testing and then come back into primary care to seek advice. And of course, the 100,000 Genome Project, where there's a lot of work happening around cancer, rare diseases, and our patients may well go through those and then come back to primary care afterwards. So I think to say that this isn't something that we're going to be exposed to will not be quite right. But really, in primary care, we're under a lot of pressure, workload implications, and this has been particularly around multimorbidity and managing polypharmacy in practice, and this is sort of the theme I just want to talk about in the next 20 minutes. So we know from epidemiological studies, from lots of good work, that there are lots of linked comorbidities around the concept of multimorbidity, and these are just sort of some of the potential diseases that patients present with. A really good initiative was the NICE guidelines on multimorbidity, which takes a sort of a generalist perspective around multimorbidity and trying to manage it as an entity within practice. But there are challenges, and there is ongoing research looking at how interventions such as longer consulting times and joint clinics with nurses and GPs can actually help manage our patients. But it's suffice to say that we're still sort of assessing that. The difficulty, though, is the fact that with each of these conditions, there's evidence drug prescribing for each of these conditions with single disease guidelines. And this is where the tension is between taking a generalist and a specialist perspective. Patient adherence. So we know that patients do sometimes have difficulty taking their medicines, and there's been good evidence and good work around patient adherence and how that could be addressed in practice. So if we're looking to look at how we might stratify care in primary care, CCGs and previously PCTs have looked at different ways in which they could re-stratify the population to try and manage our patients. And so they've used frailty, they've used age, they've used deprivation, to try and work with patients, and practices to try and reduce morbidities, to reduce A&E attendances, and so on. There are potentially new ways in which we can look at the treatment burden of multimorbidity, and this looks at targeted therapy. And one particular measure might be the polypill, which has been around for a long time, or the concept of the polypill, and still is going through clinical trials in both primary and secondary prevention. And maybe that's one potential answer in terms of dealing with the treatment burden that our patients have. So the polypill would encapsulate 3 or 4 or 5 different drugs to manage those particular conditions. So perhaps at the moment what we need to do is to look at treatment optimization, and this is based on the disease and how we might use accruing evidence that's coming through now from all the work that's happening around genomics, and how we can use that in our favor to manage our patients more effectively. And this includes sort of molecular subtyping. It includes both pharmacological treatments, but also stratifying by non-pharmacological as well, so by surgery, for example. So let's just consider a 61-year-old man who comes with 8 comorbidities, and these are listed here, with drugs, and these are just some of the drugs he might be on, and just sort of consider how we might be able to help him. So I think the slightly puzzling fact here is the fact he's 61 with breast cancer, and I'll just explain what that means in a moment. It's now feasible in primary care to collect saliva samples to genotype patients. And this is the proof of concept has been done. The work around that has been done, for example, by Martin Dawes in British Columbia, who's developed a software package that looks at a number of different drugs and looks at the genotyping of those drugs and gets patients tested and then drug dose reductions. So it's possible in primary care to actually use that as a decision support mechanism to manage patients. But again, his work requires further feasibility studies and further research around outcomes to see what difference it actually makes. But it's just an example that actually, things could be implemented in primary care. And so what we're doing is looking at genetic diversity to optimize drug treatment. And this looks at understanding disease pathogenesis based on genomic information. It's based on prescribing drugs that focus in on particular drug targets. It's looking at individual drug responses. So this is looking at the pharmacokinetics of drugs, understanding the metabolic pathways, looking at the interaction between gene variants, and then looking at the pharmacodynamic effects, and this is particularly efficacy and reducing toxicity. So this has been, I think, around for a long time, but the difference now is the fact that there's new genomic information accruing all the time. We're learning new things very quickly. So we're moving from pharmacogenetics, which is sort of understanding genetic variation in drug prescribing, to pharmacogenomics, which is using genomic information in our prescribing and understanding of drug treatments. So in my day when I was at medical school, which was probably about 5 or 6 years ago, we concentrated on sort of single gene variants and had some understanding about the concept of pharmacogenetics. But we're now moving to looking at smaller effect but larger amounts of gene variants which may influence treatment. And it's sort of understanding the biological pathways associated with that. So I just want to exemplify 2 conditions where our understanding of disease pathogenesis does make a difference, and then just 1 or 2 examples around treatments that could occur in practice. So I said this was a 61-year-old man who had breast cancer, and breast cancer in men is a rare event. And so he's represented by the square on the far left-hand side. But he's got family members who have been affected with cancers at a young age. And this becomes a bit of a red flag in terms of thinking from a genetic perspective. And the importance of recognizing these type of families and this type of individual who's been affected is that treatment protocols can change as well. So, for example, if you're thinking about chemotherapy for him, chemotherapy can now be tailored to specifically based on knowing what the BRCA status is of patients. And they have generally, I think, better outcomes. And then the other options are the way that you also think about chemoprevention in the future to prevent secondary recurrence as well. So understanding, a genetic disorder like BRCA is really important. But what's also coming through the cancer program is gene panels and cumulative gene panels, which sort of give a potential risk in terms of developing cancer as well. So the Stratified cancer program is really taking shape. And then, so if you think about breast cancer as an example where knowing genetic information does make a difference, you can apply that principle obviously to lots of other conditions. And these are all these conditions on the left-hand side, and some of the potential areas of study where understanding the underlying physiology and genomics may actually make a difference to treatment. So if we look at diabetes, this is a gene panel. So on this side here are sort of single changes in the coding called single nucleotide polymorphisms. And this is showing the association of these gene variants with phenotype. So at the top, there are different presentations to which people may present with. So high HDL cholesterol, high BMIs, development of type 2 diabetes. So the darker the color, the greater the association. And in fact, this type of gene panel has also been shown to be linked with, with weight and obesity as well. So this type of new information that's coming through, may well help us in the future in terms of managing our patients. But I think the challenge for primary care really is firstly understanding what these variants mean, how you record this in practice, how you have conversations with patients. It just opens up a whole new way of consulting with patients. And then thinking about treatment optimization in practice. This was a bit of a surprising statistic to me in that there are at least 150 drugs that have got pharmacogenetic labels which have been issued by the FBA, which covers a whole range of exposure and themes around the use of genomic information. And so if we use codeine as an exemplar of that, there's good understanding of how codeine is metabolized, and there's one particular variant called CYP2D6, which is part of the cytochrome P450 system, which helps to metabolize codeine to morphine, and morphine is the active ingredient that gives us the pain control we need. And how quickly you metabolize codeine to morphine is really quite important. And if you're an ultra metabolizer, then you could quickly metabolize codeine to morphine with the risk of potential toxicity. Now, it's relatively small numbers of patients in practice where this might happen, but we need to understand that it could. And similarly, if you're a poor metabolizer of codeine, the efficacy is going to be reduced in terms of drug administration. So there is guidance that's provided both by the FDA and MHRA to say be careful about the use of opiate toxicity, particularly in children with codeine prescribing. Another case is, I mentioned tamoxifen earlier, and tamoxifen is metabolized to two active ingredients, so 4-hydroxytamoxifen and endoxifen. And how you metabolize tamoxifen to these metabolites may affect efficacy. So this is an example of where you get differences in the gene variant at CYP2D6. So just go back here, you can see how it acts. And these are showing that the time to recurrence, the event-free survival, and disease-free survival are all better if you're extensive metabolizer of CYP2D6. So if you're good at metabolizing that to 4-OH, tamoxifen and endoxifen, then you might do better. The difficulty is that there have been many trials that have looked at this, and there have been confounding findings from it in terms of treatment outcomes. And there has been some work looking at the relationship between co-prescribing tamoxifen with other drugs, in particular SSRIs, which blocks the effect of this particular enzyme that metabolizes tamoxifen. So, again, we commonly prescribe antidepressants in primary care. We do prescribe tamoxifen in primary care. There is the potential for adverse outcomes, and we just need to be aware of that. And then I just want to mention this work that was done by Munir. So I'm not going to embarrass myself by talking about it in detail. But there are two particular gene variants that affect warfarin metabolism. And Munir demonstrated that by genotyping patients and then using that to prescribe warfarin, so guiding your dosing, does make a difference, both in the length of time that you're in the therapeutic zone for INR prescribing. So I won't say anything more about that, Munir, but it's just an example of how that could be implemented in primary care. And Munir was telling me this morning that around Liverpool, they are actually implementing that in practice. And then finally, another commonly prescribed drug is clopidogrel in primary care, which is used particularly in the management after a transient ischemic attack. And again, co-prescribing with drugs such as PPIs has been shown to make a difference. Recently, there has been meta-analysis that shows that actually, at the end of the day, it may not be that significant, but there were warnings issued by the FDA about this potential relationship. So really, I should have been talking about how we could manage things from a generalist perspective in primary care. There are ongoing studies that are looking to see how we can manage multimorbidity in practice. But in the meantime, there's new information that's coming through, genomic information, that may well help us treat our patients, both in terms of improving efficacy and reducing toxicity. Clearly, it needs more study and trials, and we'll see how that develops in the future. But I would argue that genomics information in primary care is going to become increasingly useful over time. I'll stop there. Thank you.